This is the introduction to the musculoskeletal system. We're going to start with a brief review of musculoskeletal, which includes joint anatomy and physiology. We'll then talk about the approach to a patient with a joint complaint, and we'll define some commonly used terms. At the very end, we'll describe some common fracture types and some basic considerations for specialist referral and patient education links. You know I could talk about anatomy and physiology for a long time, but since I bored you all to death over the summer in 250, I promise to be really brief here. But musculoskeletal, more than any other unit, is really important to be grounded in the basic anatomy and physiology. When you're assessing a patient, you need to understand the basics of the bone structure and the muscle and the joint components that surround those bones. In order to do that, you also need to think about the physiology. And with the physiology, we'll be talking about bone growth and bone repair and the different types of joints. The reason we need to talk about the different types of joints is because many of our joints are synovial, and we need to really understand what is both inside the synovial joint and surrounding and stabilizing the synovial joint to really understand the different pathology associated with issues with synovial joints. So the musculoskeletal system is bones, muscles, and the tendons that attach the muscles to the bones, the ligaments that attach bones to bones, the joints where two bones meet, and all of the structures within and surrounding those joints. It also includes the cartilage, which covers different surfaces of the bones. The functions of the musculoskeletal system include movement, support, and leverage, mineral storage, primarily calcium and phosphate, fat storage through the yellow bone marrow, especially in adults, blood cell production through the red bone marrow, particularly at the ends of long bones, and protection of the soft tissues. There are many different types of bones which can be classified according to their shape. Primarily, we're going to talk about the long bones, and that is the bones that make up the limbs. So the arms, the legs, and then there are also the tiny long bones that are found in the fingers and the toes. Those will be in the digits. The short bones are boxy-shaped bones. Those are unusual. We'll find those in the wrist, in the carpal bones. We also have flat bones, which are thin parallel surfaces. Primarily, we see those in the cranium. Irregular bones are unusual bones, like the vertebrae, and they have a complex shape. If you don't remember the structure of a long bone, take a moment to pause and draw it out. We drew it in 250, but I'll take just a second to review. If you need more, it will be worth your time to go through the vocabulary and the locations of the long bone areas here. So physis is the root word for growth or nature. So you're going to see physis in a lot of these terms. So epiphysis is upon or above the growth plate. So the epiphyseal line is the line where growth occurs, and above that, on the ends of the bone, we'll have the epiphysis. Between that, you'll find the diaphysis down the shaft of the bone. And in the middle of the diaphysis and the epiphysis, you'll have the metaphysis, which is in the middle. Surrounding the bone, we have connective tissue structures, which is the periosteum, and lining the internal aspect of the bone is the endosteum. It's really important to remember that there's a huge blood supply, nerve supply, and connective tissue surrounding the bones. Because particularly when we think about pathology of bones, we need to remember that bones are like living organs. Here's a better picture of a real long bone, and you can see the cross-section of the bone. I like this one because you can see all of that blood supply in there. You can also see the spongy bone, which is here, primarily in the epiphysis, and also lining the internal cavity. So in the middle here, in the diaphysis, is where you would find the medullary cavity in adults, generally full of yellow bone marrow, but in children, full of red bone marrow. And the red bone marrow in adults will be concentrated then at the ends of the bone. Here's the periosteum, which is pulled back here to show some of the perforating fibers as it's attached to the bone. Remember that there are two main types of bone. There's the compact bone, which is organized into dense, solid units that we call osteons, and they look like the tree ring structure that you see here. There's also spongy, which can also be called trabecular or cancellous bone, which is a lattice-like network, more internal to the bone, collected at the ends or the epiphyses. The bone marrow will be found primarily within the spongy bone, the red bone marrow forming the red blood cells, and the yellow bone marrow forming a site for lipid storage. Bone growth occurs through the process of ossification. Again, if you don't remember the processes of ossification, take a moment to pause here and remind yourself. Endochondral ossification happens primarily in the long bones, and it starts with the hyaline cartilage framework during development. So about 6 weeks after fertilization in embryonic development, and then will continue through adulthood, depending on the bone. Some bones take a very long time to complete their growth. Intramembranous ossification is that which occurs in the flat bones, and it starts within fibrous connective tissue. Bone repair is the process that happens after a bone is broken or injured. You'll first have a hematoma, where you'll have a blood clot closing off the injury and an inflammation reaction. Up to the second week after the bone injury, you will then have granulation tissue where the fibroblasts increase and the vascular tissue increases. About 4 to 16 weeks after the injury, you will then have callus, spongy bone replacing cartilage, and compact bone then formed and thickened. This is similar to the process of ossification, where it requires osteoblasts and osteoclasts. About 3 to 6 months later, you'll have remodeling and reshaping of the final structure of the bone by osteoclasts and osteoblasts. All right, joint types. So there are fibrous joints, which are connected when the two bones are connected by dense, fibrous connective tissue fibers. They typically have no movement. Cartilaginous joints, which are bones only connected by cartilage, and they have little to no movement. Think of the pubic symphysis as a cartilaginous joint. Synovial joints. Bones are then connected by a joint capsule, and we're going to mostly be talking about, during this unit, the synovial joints. The synovial joints are the freely movable joints. Just about every common joint complaint is going to be surrounding a synovial joint. So that is the joints of the shoulder, the hip, the knee, all of the joints that contain fluid. So synovial joints are connected by a joint capsule surrounding a fluid-filled cavity, and that fluid, of course, is the synovial fluid. So the synovial joint structures. On Tuesday, when we come into class, I want you to be prepared to go through with your groups the structure of a synovial joint. We're going to make sure that everybody understands and remembers all the parts of a synovial joint. This is really going to help you as you move through this unit and talk about the different conditions that affect the synovial joints. So remember, at the ends of each bone, you will have the articular cartilage. That's hyaline cartilage that absorbs compression and reduces friction. Then you're going to have the joint capsule itself, and the joint capsule will be made up of a synovial membrane and a fibrous capsule. Inside that joint capsule, you're going to have the joint cavity, which is filled with synovial fluid. Synovial fluid is a fluid that you can analyze. It's a viscous fluid that is going to be lubricating and nourishing the chondrocytes, or the cartilage cells. It's also a shock absorber. You'll be learning about each joint, and as you learn about each joint, you'll learn the particulars of the reinforcing ligaments. Some will be inside the joint capsule, or intracapsular, and some will be outside the joint capsule or extracapsular. This is important because when a patient comes to you with different types of pain, you're going to understand as you go through the different components of physical exam and history that pain presents differently when it's inside the joint capsule versus outside the joint capsule. In most joints where we have ligaments, tendons, or muscles that are rubbing and causing friction, you're also going to have individual bursae or a bursa. These are small synovial fluid-filled pockets that are surrounded by connective tissue. A large bursa is a tendon sheath. That's an elongated bursa. For example, we have a very long tendon sheath in the shoulder. In the knee, we have particular fibrous cartilage pads that help to improve the joint fit, and these are the menisci, or an individual meniscus. When you go through each of the different parts of the unit in the next couple of weeks, you're going to talk about and focus on, for each lecture, a particular joint. So you're going to have a lecture on the shoulder and the elbow. You'll have a lecture on the wrist and the hand. You'll have 2 lectures on the spine. First, we'll talk about cervical and thoracic spine, and then we'll talk about lumbosacral, etc. So take a moment to remind yourselves of the different bones and the structures that make up each joint. Make sure that you ask your lecturers questions about the anatomy. And you can always come to me. I'm going to have a bone box this next couple of weeks, and I'm happy to show you the different parts of the bones that come together to form the joints. I made some fun videos this spring break. I found some 3D technology, and I wanted to give you guys some examples of synovial joints. So if you want to take a moment to look at the 3 joints that make up the pectoral girdle, this is optional, but I'd love to hear what you guys think of this fun new 3D program that I have. All right, let's move on now to talk about the approach to musculoskeletal complaints. Of course, we'll be referencing your Bates textbook, and you're going to learn a lot more in clinical skills this quarter. We're also going to be using an orthopedic surgeon developed textbook, which is the Sarwark, and you're going to see that you have a lot of readings this unit that are from the Sarwark textbook. So we'll talk about the approach to a patient through both physical exam and history, and then we'll briefly touch on imaging. So musculoskeletal conditions. The common musculoskeletal conditions are fractures, dislocations, low back pain is extremely common, strains, and arthritis. The red flag conditions have been highlighted in the list posted by the IORs this quarter, and they include septic arthritis, certain types of fractures, many other conditions. Keep an eye on these. Harrison's has a little chart that talks about the most common musculoskeletal conditions. And the reason for doing this is that as you're assessing a patient, it helps to understand what is the most common as you're trying to just logically determine what's wrong with the patient. You may also consider other factors such as age. Some conditions are much more common in older patients. So musculoskeletal complaints account for over 315 million outpatient visits per year in the U.S. They're a leading cause of disability, they're a common cause of chronic pain, and they're projected to increase as our population ages. Just some examples. Arthritis is extremely common. 54 million adults, that's 1 in 4 in the United States, are affected by arthritis. Of that 54 million, almost half, 23.7 million, have limited activity due to their arthritis. The Center for Disease Control has projected that this will increase much more over the next several decades as our population ages. So the approach to musculoskeletal complaints is described in Harrison's as well as Bates and the Sarwark textbook. Musculoskeletal disorders may be very challenging because sometimes it takes time for the symptoms to evolve into a full condition. It may also take time to diagnose and truly understand because many of the symptoms for conditions are very similar. And those symptoms may also change as the patient and the condition progresses. Consider the following when a patient presents with a joint complaint. You want to know, is it within the capsule, within the joint capsule, and the structure's actually within the joint itself? That would be intra-articular. Or is it just surrounding, peri, or extra-articular, just surrounding that joint capsule? Maybe it's in a bursa or in a supporting extra-articular tendon. Is it acute or chronic? Harrison's considers chronic musculoskeletal to be anything more than 6 weeks. Is there inflammation present? How many joints are involved? And is the joint involvement symmetric? Harrison's also has a nice algorithm for musculoskeletal complaints. This algorithm is used and repeated in other textbooks, including Bates. So it includes those same questions that were just posed. Is it articular? Is it chronic or acute? Does it signal inflammation? How many joints are involved? And if you have multiple joints involved, is it symmetrical? So let's first talk about articular versus non-articular. An articular complaint is going to be within the joint capsule or inside of the joint capsule itself. So that can include the synovium, the synovial fluid, the articular cartilage at the ends of the bones within the joint, intra-articular ligaments, ligaments that go within the joint capsule, and juxta-articular bone, or those ends of bones that are just inside the joint capsule. The complaints associated with articular joint conditions are going to be diffuse and deep pain. You're going to see limited range of motion, often swelling, crepitation, or that joint clicking that you get during movement, joint instability, locking, and possibly joint deformity. These all depend on the condition, of course, but these are the types of complaints you might want to be looking for. When you look at your range of motion for articular, you're going to also see a decrease in both active and passive range of motion. I want you to compare that to the non-articular conditions where you will see decreased active range of motion, but passive will typically be normal. The structures for non-articular, which can also be considered peri, or surrounding the joint capsule, will be extra-articular ligaments, tendons of muscles nearby, bursae, muscles themselves, fascia, bone, nerve, skin. These tend to be focal tenderness or point tenderness, easier for the patient to point to, and the physical findings may be remote from the joint capsule. The next question you want to ask in your physical exam is, do you see evidence for inflammatory? Inflammatory disorders can be infectious, crystal-induced, immune-related, or even idiopathic. You will see pain, swelling, and warmth, those cardinal signs of inflammation. But one note here, redness is not always present. It has to be a fairly superficial joint, like the joints of the fingers, for the redness to actually show. The patient will often then complain of fatigue and prolonged stiffness that improves with activity. So you want to ask, what improves the condition and what makes it worse? So if activity makes it better, you may consider an inflammatory condition. Non-inflammatory disorders are typically caused by trauma, repetitive use like bursitis, degeneration, neoplasm, or pain amplification conditions like fibromyalgia. In this case, you'll typically have pain without swelling or warmth associated. You'll have intermittent stiffness that is exacerbated by activity. So when you're doing your musculoskeletal inspection, Bates suggests, not just me, I know I'm the anatomy person, Bates suggests, so I can say it, that you always start with the anatomy of the joint. You want to start with the foundational bony structures and landmarks. You're going to use your surface anatomy for palpation and orientation. You're going to think about the bones that make up each joint. Then you're going to think about the type of the joint. Is it a synovial, cartilaginous, or fibrous? And think about the structures nearby that may be affected, articular versus non-articular structures. If you find that it's non-articular or periarticular, you also want to think about the muscle groups. So understanding the muscles that move the joint can help you to understand what may be affected by the particular condition, but also will help you understand your range of motion and other analyses that you will do. So you want to think about your primary movers of muscles, your stabilizing muscles, and the location of the tendons when you're doing your different tests. Then you also don't forget that you have surrounding tissues. You can have skin and subcutaneous tissues that can be inflamed or damaged by conditions. You have nerves, lymph nodes, and blood vessels that can also be affected by nearby trauma or other conditions. The next thing you'll do is your range of motion. You want to understand the normal range of motion to help test the function and stability of the joint. Your different tests will tell you the integrity of the ligaments, the tendons, and the associated joint structures. So it's a good idea to review the movement types, flexion, extension, etc. I'll show you a picture. And you're going to do both active, where the patient performs the motion, and passive, where the examiner performs the motion. You want to think about, when you're doing your range of motion tests, is it limited? Is the movement inhibited? Or is it lax? In some cases, you'll have excess movement. Here's some reminders of those different types of movements. So remember that flexion is bending. Anything that's bent is flexed. Extension is straightening. Anything that's straightened is extended. You also have abduction and adduction, which is in reference to the midline of the body. So abduction is moving away from the midline. Adduction is adding, we say it's going back, or you're adding back to the midline. Then we have other specialized movements that can be different for each joint. So the feet, the jaw, the fingers, they have other specialized movements like dorsiflexion, plantar flexion, etc. When you do your musculoskeletal inspection, in addition to range of motion, you also want to pay attention to the patient's posture and gait. You want to inspect the patient's standing posture and the gait to help determine the limitations and the weakness of affected areas. Here's an article from Family Practice Journal that talks about evaluating a patient with hip pain. These articles are very important and helpful for updating your current methods. You want to assess the symmetry and compare affected and unaffected areas. You will also do motor and sensory tests. Muscle strength testing can help diagnose pathology related to tendinopathies or tears. If you have a condition in the neck or back, then you might have some spinal pathology, which can affect the function of the nerves. So then you're going to go in and do your sensory and motor testing as well, which can include your reflex testing, strength testing, of course, as part of your motor testing, and peripheral nerve function tests included. You also want to look for signs of inflammation, as we said, those cardinal signs: heat, swelling, pain, redness, maybe. It depends on the joint. You may not always find signs of redness, but you'll usually find some warmth if you compare to the unaffected joints. Definitely swelling and pain. The systemic signs of inflammation are ones to keep an eye out for. Those will be fatigue, fever, rash, and weight loss. You can also, of course, use your laboratory findings as well. If you're looking particularly at autoimmune conditions or other systemic signs of inflammation, you might have changes in ESR, CRP, or hematocrit, looking for thrombocytosis and anemia. All right, so that's physical exam basics. Let's talk now about patient history. So you want to think about the patient profile, especially with respect to age. As I said, Harrison's uses the age of 60. There are many conditions that are much more common over the age of 60. There are also many conditions that affect women more than men, and vice versa. So taking into account the patient's age and the gender can really help to narrow down some of the possibilities for particular joint conditions. There are also genetic factors, so race and ethnicity and other risk factors can be accounted for if you're having difficulty with the diagnosis. You want to think about the chronology of the complaint. If it's an abrupt onset, it may signal one of the more red flag conditions. But you want to think also about evolution. So you may be early on in a condition, you may not see much. It might be intermittent. It might have phases where it goes on and off. It might be chronic. You want to know the total duration. How long has the patient had this complaint? And then you want to think about the extent of joint involvement. You want to look at the number of joints affected. Is it a single joint? Is it multiple joints? You want to think about the location and the radiation of the pain. One trick here that's suggested by many of the references is to have the patient point to the location of the worst pain. Because patients themselves can have difficulty locating the pain, pointing to the pain can help you narrow it down. And then finally, symmetry. Precipitating factors, what may have led up to the condition: trauma, drugs, changes in certain medications can cause certain musculoskeletal conditions. I'm sure Dr. Liu will have a lot to tell you about these. Other illnesses or comorbid conditions that might make certain conditions more likely. For example, did you know that in diabetic patients, carpal tunnel is fairly common? Aggravating and relieving factors, we already talked about this, but some conditions improve or worsen with activity. Sarwark has, in the Sarwark textbook, there's a nice summary of some reasons to use particular types of imaging over others. So this figure I made from both Harrison's and Sarwark, but if you look in Sarwark, there's a nice little diagram which lists them all out and gives the pros and cons. For plain X-ray, it's simple and it's inexpensive. You're probably going to get X-rays on just about all of your musculoskeletal patients, but it has poor tissue contrast, so it's not great for soft tissues. Ultrasound, it's safe, it's inexpensive, and there's no radiation. But the problem with ultrasound is that it's a small field of view, so you may not always get what you need. Bone scans can show metabolic activity, but they're nonspecific and the detail is very poor. You can also use arthrography, typically combined with other modalities, and this requires contrast medium. CT is 3D capable and high detail, but it has poor soft tissue contrast. So, of course, MRI then will be used if you want really good contrast resolution, but MRI is expensive. Let's take a look at this example here, where you can see the hip joint in a plain X-ray compared to an MRI. What do you guys see here? Yeah, do you see that? No, okay, you cheated and you read the caption. But what you can see here in the MRI is there's osteonecrosis or degradation of the bone because of a lack of blood supply. That's really evident in the MRI, but it's not very evident or not evident at all in the X-ray. Let's do a couple of definitions and resources, and then you guys will be off to move on to the rest of your unit. So some common terms for musculoskeletal. A fracture is a break. A break, a crack, a fracture, it all means the same thing. Any place where the bone is broken is a fracture. A dislocation is when the bone is displaced from its normal joint position. A sprain is referring to ligaments. So this is either a stretching or a tearing of the ligament. A strain is a stretched or torn tendon. So that's where the muscle attaches to the bone. And you're going to hear many of the itises. Remember that the root word itis stands for inflammation. Bursitis will be inflammation of the bursa. Tendinitis will be inflammation of the tendons. Synovitis, synovial membrane inflammation, etc. One thing to note, though, is that arthritis is a very general term for joint inflammation, and it's not necessarily extremely helpful to see the term arthritis. There are many arthritic inflammatory conditions of the joint. Fracture types. You're going to see in the textbooks a lot of different kinds of fracture types and fracture terms. What you want to know for this is that fractures are generally organized by their descriptive terms. So fracture types are descriptive. First, is it open or closed? Terms for open and closed are simple and compound. So compound is when the bone breaks through the skin. That's open. Simple is when it's closed or the bone hasn't broken through the skin. That's really important because if it has opened up to the environment, then that can be high risk for infection, and that's going to be immediately, almost always, aggressively surgical to clean out. You will also then see descriptive terms for what direction the break occurs. So oblique is at an angle to the long bone. Spiral will be rotated will be fracture during rotation movements. You'll have transverse, which is where it's across, straight across, with respect to the long bone. And you'll have other descriptive terms, unusual ones. Grain stick. Does anybody know what grain stick means? Green stick refers to those green tree branches that you try to break. So you ever try to break a green tree branch and it doesn't break fully? You have one side that breaks and the other that stays complete. This is really common in children. You'll have impacted, where one compresses into the other areas of bone. Compression fractures, where you'll have crushing of the spongy bone. Stress fractures. Comminuted is multiple bone fragments. So get familiar with these terms and be able to describe fractures, but the most important is to know how to treat them. There are many specialists you will want to consider referring to. So nearly everybody is going to go to radiology, but not always. For example, an early arthritis patient is not going to see much if you send them to radiology. But you're usually ruling out even in those cases. So radiology, just about everybody. And then all the other specialists are going to depend. If they're surgical candidates, they're typically going to go to orthopedics, and you'll have specialized referrals for orthopedics. You'll have the hand surgeons, you'll have the spinal surgeons, etc. If it's an inflammatory or autoimmune condition, particularly those that you're having difficulty diagnosing, you'll send them to rheumatology. Podiatry will be foot specialists. And then, of course, you want to think about long-term management for some of the more chronic conditions or even post-surgical. And that's where you'll think about physical therapy and pain management. I've put neurology and nephrology in here because what you'll see in your neurology unit after you've gone through musculoskeletal is that a patient that comes in complaining of weakness is a complex patient. There's a lot of reasons for muscle or joint weakness, and you always want to consider both ion and other disturbances, acid-base, that could be leading to muscle weakness, medications, and also neurological conditions that could be leading to muscle or joint weakness. All right, finally, I've compiled some patient education resources for you. These are all of the most common places where you can find some good MSK, musculoskeletal patient education. So we have the National Institute of Arthritis and Musculoskeletal Skin Disease. We have the American College of Rheumatology. We have the American Academy of Orthopedic Surgeons. This is the group we can thank for your SARWARC textbook. We have the American Academy of Family Physicians and the American Association of Nurse Practitioners, all with great resources to send your patients to, but also to print PDFs of different resources for your patients. All right, that's it. These are my references. Welcome to the musculoskeletal unit, and we will see you all on Tuesday.